And this is an important topic that I'm going to take. It might take a little longer. Approach to hemolytic anemias. The approach to hemolytic anemia will depend on 1, the clinical history. Therefore, the presentation. For example, gallstones and spirocytosis, leg ulcers and sickle cell anemia. Duration of the hemolytic anemia, whether it is acute or chronic. History of fever can be malaria. Family history, thalassemia, sickle cell anemia. Any of the transfusion therapies. Drug intake, for example, primaquine. And clinical presentation of jaundice, failure to thrive, skeletal abnormalities, etc. So this will be a clinical picture of the hemolytic anemia. Have it in one corner of your mind for your medicine also. And what are the investigations that can be done? Each one of this, I would like you people to kindly memorize. GSS. Osmotic fragility test, spirocytosis, sickling test for sickle cell anemia, electrophoresis for sickle cell anemia, thalassemia, Coombs test, autoimmune hemolytic anemia, blood group incompatibility, Hamm's test for PNH, Landsteiner's test for paroxysmal cold hemoglobinuria, an enzyme assay, G6PD, pyruvate kinase deficiencies, etc. So you have got a good number of a panel of tests which you can have as MCQs, answer in the Viva or part of the essay. The screening test for any of it will be routine hemogram. Any anemia, please remember routine hemogram. Morphological abnormalities such as sickle cells, spherocytes, nucleated RBCs, bite cells, etc. Inclusions bodies such as the Howell-Jolly bodies, Haynes bodies, etc. Stool examination, stercobilinogen, and the others are seen in hemolytic anemias. Radiological abnormalities for the skeletal abnormalities. Specific investigations can be done. For example, sickle cell anemia, you have got the various reduction tests. The general biochemical test will be hyperbilirubinemia, plasma haptoglobin, hemopexin are reduced, haptoglobin and hemopexin are all reduced, serum. And methemoglobinemia in Coombs test will be positive. Hemoglobinemia, there is a pink plasma because of hemolysis. And hemosideruria, Prussian staining is positive in the tissues of the bone marrow. The next one will be the classification of hemolytic anemia. I've already covered it. I'm repeating it because it is of paramount importance. Look at this, for example, it can be because of intracorpuscular defects. So within the RBC, it can be membrane defects as in these cases. Spherocytosis, erythrocytosis, stomatocytosis. Hemoglobin defects as in the case of sickle cell anemia, hemoglobin CD. Thalassemia, again beta and alpha. Enzyme defects, pyruvate kinase deficiency, G6PD. Any drug induced. And paroxysmal nocturnal hemoglobinuria. Another thing will be the extracorpuscular defects. It can be immune mechanisms. Here I mentioned warm antibody, cold antibody. Hemolytic disease of newborn. Incompatible blood transfusion. ABO or RH. Mechanical trauma, March hemoglobinuria. Cardiac valves. Microangiopathic hemolytic anemias. These are all non-immune mechanisms. Apart from that, it can be because of drugs, chemicals, infections, and poisoning. Please remember this entire list. Thank you again. I completed a very important topic.